Hello and welcome to the Surgeon's Burrow. In this video, we will be discussing the cardiopulmonary bypass machine. Now, what does this machine do and what does it mean? As the name suggests, it is a cardiopulmonary bypass. So, basically, it is a machine which is bypassing the heart as well as the lungs. And while it is bypassing the heart and the lungs, the function of both the heart as well as the lungs is taken over by this machine. So, now where is this machine used? This machine is used in any surgery in which the heart and lungs need to be stopped temporarily and their function is replaced artificially. It is replaced artificially by the CPB machine. So, in any heart surgery it is used. For example, if you want to do any valve surgery under direct vision, so why is this word direct vision mentioned here? Because there are a few valve surgeries which are being done endovascularly. That is not being done under direct vision and that does not require a CPB machine. But if you want to operate on the valves under direct vision, then you have to use a cardiopulmonary bypass machine. Also, if you want to do any reconstructions, for example, if you are doing a CABG, a coronary artery bypass graft, you need to use a CPB machine. Now, this box, which is taken from Bailey and Love, it enumerates the alternative uses of a CPB machine. So, rewarming from profound hypothermia. Now, supposing there is a patient who has been trapped in snow or who has become hypothermic and you need to rewarm the patient, you can use this cardiopulmonary bypass machine to rewarm the patient. How it is used, we will be discussing it during the course of the video. You can also use it since the CPB machine is taking over the function of the lungs. You can use it to resuscitate a patient in severe respiratory failure. You can use it as an adjunct in pulmonary embolectomy. You can use it in single and double lung transplantation. So, now all these three is where the lungs are being used. The lungs are not functioning and you need artificial lung support. It can also be used in cardiopulmonary trauma. It can also be used in certain non-cardiac surgical procedures. So, here earlier I mentioned that this machine is used for surgeries on the heart. But in certain non-cardiac surgical procedures, for example, if you want to resect a highly vascular tumor and tumors which involve or which invade the large blood vessel, that is the aorta and the vena cava or the pulmonary veins, then you will need this CPB machine. Now, as for any surgery, how do you approach the heart? So, the most common incision by which the heart is approached is a median sternotomy. So, in a median sternotomy, the incision is made, as you can see in this diagram, it is made from the suprasternal notch to the lower end of the xiphisternum. Now, once you make the incision, as is indicated by the dotted lines in this diagram, you divide the sternum and you retract the sternum. Now, once you retract the sternum, what are the structures that you are going to see? So, this diagram taken from Netters shows those structures. So, you will see this thymus superiorly and you will also see the pericardium inferiorly. It is inferior to the thymus. Pericardium is the layer of the heart. Now, the thymus in adults is usually avascular and atrophic, but sometimes it can remain relatively vascular. So, you need to dissect this thymus very carefully from the heart, from your operating area to prevent any injury. Now, once you dissect the thymus, you are next going to dissect the pleura. You dissect the pleura from the pericardium and then you open the pericardium. Alright. Now, this is what of detail here is the most common incision called a median sternotomy. Now, sometimes you can also use alternate incisions such as a left anterolateral thoracotomy or a right anterolateral thoracotomy. Now, these incisions are used in two reasons: for minimally invasive surgery, and secondly, if you want to do any specific surgery on the descending aorta. So, where you do not need that much amount of exposure, you can use either left or a right anterolateral thoracotomy. Now, in this diagram taken from Fisher's, it indicates a right anterolateral thoracotomy. So, this, as is obviously seen in this patient, this incision is being made on the right side. Okay, now, so you have made your incision, you can see the heart, you have dissected the thymus and the pericardium off the surface of the heart. What do you do next? Now, you have to cannulate the patient. Now, what does this cannulation mean? We will discuss. But very important, before you cannulate the patient, you have to completely heparinize the patient. So now heparin is an anticoagulant. So when you completely heparinize the patient, no blood clots are being formed. This is very, very essential because after all, you're going to use a CPB machine, which is a non-physiologic surface. So you will not want clots. So now what do you cannulate first? I'll use a different color. What do you cannulate first? You will first cannulate the arteries. So after you expose the great vessels, you will insert an aortic perfusion cannula. This aortic perfusion cannula is inserted into the ascending aorta. So ascending aorta, bear in mind, is the first vessel which is getting cannulated. Now once you insert the cannula, you hold it in place via a purse string suture, then you exclude air because you do not want an embolism. You exclude air from the circuit, from the cannula, and then you connect the cannula to the bypass circuit. So far where have we come across? Till where have we reached? We've made the incision, we've exposed the heart, and we've cannulated one structure, one vessel so far, which is the ascending aorta, and we've connected the cannula to the bypass circuit. Now you can always use an alternative site. Now which are those alternative sites and when do you use them? So firstly, supposing if it is inadvisable to cannulate the ascending aorta. For example, if the patient already has an aortic dissection and you have to operate in that area, or because of the aortic dissection, your cannulation is being prevented, it is inadvisable. So in that scenario, you will use an alternate site. Supposing if it is impractical, that means you are operating on that area itself. For example, if you are doing an aortic root surgery, or if it is impossible, due to some reason, maybe because the patient has undergone radiotherapy in the past, or maybe because the patient has been operated in the past, there are severe dense adhesions present. So in this scenario, it becomes impossible to operate on the heart. Now when there are adhesions, it is impossible to operate. It is very difficult to operate in the bowel itself. So imagine how difficult it would be to operate on the heart when there are adhesions. So in these two scenarios, you will use two alternate sites. You can either use the femoral artery or you can use the axillary artery. Now among these two, which is better? The axillary artery is gaining more popularity of late. This is because it provides antegrade flow when compared to the femoral artery. So now this is it. For now, supposing this is a human being. One moment. Now this is a human being. This is the neck. This is the upper limb. This is the torso. This is the lower limb. All right. Now, if you are going to cannulate the femoral artery over here, then obviously the blood is going to go in this direction. Now, if you want to perfuse the abdomen and the other part of the body as well, so this blood is going to go retrograde. Whereas in the axillary artery, I'll use a separate color. In the axillary artery, you cannulate the patient somewhere over here, and it comes in this same direction. So it is antegrade. So this is the first advantage of an axillary artery being cannulated over a femoral artery. The second advantage is there is a theoretical advantage that if you are going to cannulate the axillary artery, you are going to have relatively fewer thromboembolic events when compared to the femoral cannulation. So the advantages are of the axillary artery. First is it is an antegrade flow. Secondly, it will reduce thromboembolic events. Lastly, an axillary artery cannulation, it can also be used to provide selective cerebral perfusion. Now, what is a selective cerebral perfusion? This will be mentioned later on in the video. Selective cerebral perfusion. So now we are progressing further. We have cannulated the aorta, the ascending aorta. Next, we are going to cannulate the veins, the great veins. So now how do you cannulate the great veins? You place a purse string suture around the right atrial appendage. So this is the diagram of the heart. This is taken from Netter's. This is the right atrial appendage. You place a purse string suture over here. We'll come back to this diagram later. You place a purse string suture around the right atrial appendage, and now you have two options. you can either use a single two-stage venous cannula. So, you can either use a single two-stage venous cannula, or you can use, or you can cannulate these SVC, the superior vena cava, and the IVC separately. Now, let us look at each one of them. After you've placed the pursing suture on the right atrial appendage, we have to insert the cannula. Now, first let us look at this single two-stage venous cannula. Now, this is a diagram of this is an image of the two-stage venous cannula. As you can see, there are holes present in the ends of the cannula. You see this circle, this is the end portion of the cannula, and this has holes. These holes that you can see, this will sit in the inferior vena cava, and on the sides of the cannula you can see these holes over. I'll use a separate color. I'll use a yellow color. So you can see these side holes. These side holes will make sure that there is blood coming into these side holes from the superior vena cava, and this sits into the right atrium. So now let us look at it. Let us look at this diagram from Netters. So this is our venous cannula. You have the two-stage venous cannula. It is sitting like this. All right. This is the end hole. I'm sorry, I'll draw it a bit longer. The end holes, this is sitting in, this is going to receive blood from the inferior vena cava. This is the superior vena cava over here, and here is the inferior vena cava. This is, I'll use a separate color, I'm sorry. This is the cannula. Here are the end holes, here are the side holes. So the end holes are for the inferior vena cava and the side holes are for the superior vena cava. The side holes, as I explained in this diagram, it sits in the right atrium. This is just a posterior view of the heart to show you where the inferior vena cava sits, or enters the heart rather. So the cannula comes like this. Now, while we were talking about aortic cannulation, I did not mention single stage and two stages. So this is an image of the aortic cannula, and see, it is slightly curved. It is slightly curved because this curvature gives laminar flow, and secondly, there are holes only over here. There are no side holes. Now, supposing if you do not want to cannulate, if you do not want to use a single stage cannula, you can also cannulate the SVC and the IVC separately. Now, what is the advantage of this? Firstly, it gives better control over venous return, because you have one cannula sitting in the superior vena cava, one in the inferior vena cava, instead of two cannulae. So obviously you will have better control over the venous return. And secondly, it will facilitate surgery within the right atrium. Because see, why does it facilitate surgery in the right atrium? Because in the stage of the two stage cannula, the side holes are sitting in the right atrium. So if you want to operate on the right atrium, you cannot use that. You will have to cannulate the SVC and the IVC separately. Now, an alternative site to cannulation of the vena cava is the femoral vein. Now, when do you cannulate the femoral vein? You will cannulate it in case you want to operate on the thoracic aorta, and if you want to do a minimally invasive surgery. Now, let us look at the cardiopulmonary bypass circuit. Before looking at the cardiopulmonary bypass circuit, let us see so far till where we've progressed. So first we made the incision, the most common incision being a median sternotomy. We retracted the sternum, we dissected the thymus and the pericardium of the heart. We entered the heart. We placed one cannula. Let me use this color for the aorta. We have cannulated the aorta over here. All right, and we have also cannulated, what color do I use? We have also cannulated the vena cava. So basically, now what is the function of the heart? Now this is very basic physiology. So blood enters from the vena cava into the heart, and the heart pumps it out via the aorta and the pulmonary artery. Pulmonary artery will go to the lungs. Now, we have cannulated the aorta first. So, we have taken control over blood that is flowing out of the heart, and we have also taken care of the vena cava in venous cannulation. So, we have taken control over blood that is entering the heart. So, we have control over blood that enters the heart, and we have control over blood that leaves the heart. Now, the heart is still it is still beating, mind you, and the heart also contains blood, because we have not yet emptied the heart, right. So, the heart contains blood, and we have not yet taken control of the heart beating. So, this is the aortic cannula, this is the venous cannula. Both these cannula are being connected to the circuit. So, now let us look at the circuit. So, you have connected the circuit. Now, the cardiopulmonary bypass machine, it takes over two processes. It is taking over two organs, the heart for circulation and the lungs for ventilation. So, now you have established full flow. That means from the heart, blood is being, instead of the vena cava, blood is entering the circuit, and the circuit itself is pumping the blood back to the circulation of the entire body via the aortic cannula. This is what is meant by full flow gets established. Then what do you do next? You stop the ventilator. Now, what ventilator are we talking about? So, before you do any surgery with the help of GAM, when the patient is going under general anesthesia, the patient is connected to a ventilator, right. This is the ventilator that is being stopped now. Now, once the ventilator is stopped, your next goal is to isolate the heart from the rest of the circulation. So, what do you mean by isolating the heart from the rest of the circulation, and why do you need to do this? So, now to recap, you have taken control over the vena cava and the aorta, alright, but the heart, it still contains blood, and we need to isolate the heart from the rest of the circulation. That means whatever blood is going to enter into the heart, or whatever fluid is going to enter into the heart, it should not enter the rest of the circulation. This is what is meant by isolation. Now, how do we do this and why do we do this? Let us look at this in the next segment. Okay, before that, now we've entered the heart, we've connected the aorta first and then the vena cava. Now, the heart contains blood. So, now how do you drain the blood from the heart? Now, the blood is drained from the heart using a siphon effect. You would have heard of politicians and corrupt bureaucrats siphoning funds. So, likewise, you are going to use gravity to siphon blood from the heart. Now, to be able to use gravity to siphon blood from the heart, you are going to have to place the venous reservoir around 50 to 70 centimeters below the level of the heart. This means now the patient is lying supine on the operating table, 50 to 70 centimeters below the level of the heart, you are going to place the reservoir, the venous reservoir, and that is going to drain the blood from the heart using the gravity. This is called the siphon effect. So, now blood enters the reservoir. From the reservoir, it will go into a circuit. We will look at the circuit later. So, now what happens in the circuit? First and most importantly, you are going to have to oxygenate the blood, because you are taking over the function of the lung. So, obviously, you need to oxygenate the blood. So, you will oxygenate the blood using an oxygenator. This oxygenator, it allows gas exchange across its membrane. Alright. After you have oxygenated the blood, you are going to pump the blood back to the body via the aortic cannula. So, you have basically now the function of this circuit is complete. Now, this diagram of the circuit of this cardiopulmonary bypass machine, it looks slightly complicated, but it is actually very simple. This is taken from Bailey and Love. So, now let us look at the components. I will use a different color. Let me erase this first. I will use a light green color. So, now here is the heart. Alright. The venous blood from the patient is entering your reservoir. This is your reservoir, filtered hard shell venous reservoir. All right. Also, there is something called a cardiotomy suction blood. That means for any surgery, whenever you are operating, you would have heard the surgeon telling, okay, give me the suction, mop the blood, or use suction to remove the blood. Likewise, in the heart, you're going to use a cardiotomy suction. So when you operate the heart is not a bloodless organ. When you open the heart, there is going to be some blood coming out. For that, you're going to use the cardiotomy suction. Now, blood from this cardiotomy suction and the venous blood, it enters this reservoir. From this reservoir, now it is blue. It is blue in color, which means it is deoxygenated. From this, it is going to go via blood pump. It is going to go into an oxygenator and a heat exchanger. This is your oxygenator and heat exchanger. Alright. So, the blood gets oxygenated over here, the temperature is regulated, and from this oxygenator, the blood, now it is red in color, which means it has got its oxygen back. It's going to go into the arterial, it's going to go back into the aortic cannula. Before that, you're going to use an arterial filter to remove any clots which may have formed, because after all this, your CPB machine is a non-physiologic surface and clots are bound to be formed. If you remember Virchow's triad, whenever there is a problem in the surface, so now using an artificial surface, there is bound to be some clotting, some inflammation. To remove that clot, you are going to use a filter, then blood, arterial blood, it enters the patient. So, I mentioned the oxygenator earlier. Now, I mentioned a new term over here called the heat exchanger. Now, what exactly is that? And basically, what else is happening in the circuit or in the circuit apart from oxygenation? So, first you have something called a heat exchanger. Now, we are using this heat exchanger to our advantage. Now, as you know, the normal body temperature, it maintains the metabolic activity at a certain temperature. If you lower the temperature of the body, the core body temperature, the metabolism of all the organs decreases, right? So, when you isolate blood into the reservoir, after isolating blood into the reservoir, before pumping it back into the body via the aortic cannula, if you decrease the temperature of the returning blood, the core systemic temperature will decrease. If the core systemic temperature decreases, the metabolic demands of the tissue decreases and you can operate for a longer time. Secondly, you are using a filter. This filter is going to remove any particulate emboli. Any small particles of emboli which are being forming are going to be removed before it enters the circulation. Third, there is also something called a suction pump, the cardiotomy suction thing which I mentioned over here, this cardiotomy suction blood. This keeps the area around the heart clear of blood to improve your vision. Now, this begs the question, okay, so I've mentioned about the systemic temperature being reduced. So now it begs the question, to what extent are you going to cool the blood? Now, the degree of cooling is managed according to the severity, that is, for how long you need to operate on the patient, for how long you need the cardiopulmonary bypass machine. It also depends on the surgeon's preference. So, some surgeons might take longer to operate, some surgeons might take lesser time to operate, some surgeons might not want to cool their patients to that extent. So, this is why it depends on the surgeon's preference. Now, there is one more entity called myocardial protection. Now, what is myocardial protection and why do you need it? So, let us recap what we've done so far. We've done the sternotomy, we've made the incision, we've entered the heart, we have cannulated the aorta and the great veins. This has been connected to the circuit. And last, if you remember, I had spoken of isolating the heart from the rest of the circulation. So, now how do you do that? And why do you need to do it? So, you will use an instrument called a cross clamp. Now, some of these cross clamps are named after Michael DeBacchi. Michael DeBacchi was a legendary cardiothoracic surgeon. He was a legendary cardiac surgeon. He operated almost up to the age of 100. I think he died somewhere in his mid 90s. and it is said that he continually operated till that age. So, this clamp is named after him. So, you use a cross clamp, and where do you put the clamp? You will put the cross clamp on the ascending aorta at the root of the aorta. So, what happens is, when you put the cross clamp on the root of the aorta, you isolate the heart from the rest of the circulation. Now, how are you doing that? This is because the coronary arteries arise from the root of the aorta. So, when you put a clamp on that, blood can enter into the coronary arteries, but that blood is going to enter the coronary arteries. I mean, the blood is not going to go proximally. So, let me make it clear. Supposing this is the arch of the aorta and you have the root over here, right? Supposing you place a clamp, I'll use a different color. Supposing you place a clamp over here. So, now there is no blood flowing here. So, this becomes isolated, and the coronary arteries which come like this are isolated. Now, why do we need to isolate the coronary arteries, and how would we use it to our advantage? We will discuss. Okay. So, now once you cross clamp the aorta, the ascending aorta, the heart ceases to eject blood. Fine. And also there is inhibition of coronary blood flow, because you're clamping the coronary arteries, right? So, there is no coronary blood flow happening. So, the heart becomes anoxic. Now, you've read so much about the brain being sensitive to ischemia, and usually whenever there is an ischemic stroke, it says that to prevent the patient from being brain dead, whenever you're doing CPR, for example, during CPR the limit is 10 minutes. So, if the patient is his heart is stopped for more than 10 minutes, that means there is going to be some brain damage. So, now what is the limit for the heart? Now, if the heart is anoxic for more than 15 to 20 minutes, so the magic number for the heart is 15 to 20 minutes, it will cause permanent myocardial damage. Now, obviously, you cannot finish your heart surgery in less than 20 minutes. So, you will require some form of myocardial protection. That means you need to inject a solution into the heart via the coronary arteries, which will prevent permanent myocardial damage. So, now how do you prevent this permanent myocardial damage? The first thing, as I have already mentioned, is you inject a solution. Now, that is a cardioplegic solution. Cardio means heart, plegia means paralysis. So, you are going to paralyze the heart, basically you are going to make the heart to stop beating. Now, how do you inject this solution? There are two ways. First, you do it antegrade. Secondly, you do it retrograde. Retrograde is, so antegrade means via the normal direction of the physiological flow of blood. Retrograde is in the opposite direction. So, supposing if you infuse this solution via the coronary sinus, then it is called retrograde. So, now the next question arises, what solution do you use? Now, there are various cardioplegic solutions, and these solutions, they vary in terms of the temperature, the pH, the arresting agent that is used, the osmolality, and also on the presence of red cells as well as other factors. But what is common to these solutions? Most of these solutions, the arresting agent in these solutions is potassium. Now, this potassium, it will arrest the heart in diastole by depolarization of the myocyte cellular membrane. This means when the heart is arrested, it is arrested in diastole and it is arrested by a depolarization. These are important terms which you need to remember. Now, you can use two kinds of solutions. You can either use a cold isotonic crystalloid or blood solution, or you can use a warm cardioplegic solution. Now, the temperature of a cold solution is 4 to 10 degrees Celsius, and warm is like how you use warm saline during when you are giving a peritoneal wash, for example, you are going to use warm saline. Like that, you can use a warm cardioplegic solution. Now, each has its own advantages. The advantage of a cold solution is it aids the myocardial protection by reducing the metabolic requirements through local hypothermia. So, as I explained earlier, when you inject a cold solution into the heart, the metabolic requirement of the heart decreases and that protects the heart. Secondly, if you're, okay, sorry, this was the cold solution. And what is the advantage of the warm solution? A warm, so now after you have reduced the metabolic requirement and you've done your surgery, what you can also use, you also need the enzymes to get reactivated. All right. So how so to reactivate those, I'm sorry, I'm a bit distracted by my notification. You can use a warm solution. The using a warm solution, it facilitates better myocardial recovery post operatively by aiding activation of the intramyocardial enzymes, because enzymes, as you may recall from your preclinical knowledge, it activates at the body temperature. So if you use a warm solution, the enzyme get reactivated. So the first method of arresting the heart was via cardioplegic solution. There are two methods in that. One is antegrade, second is retrograde. Third, you can use something called an intermittent cross clamp fibrillation. What do you do in this? In this, intermittent ventricular fibrillation, that is VFib, is induced via a small electrical charge. So when the heart gets arrested, it does not eject, but because it is fibrillation, it is beating at a very high rate, it does not eject, and so it is relatively still. Now obviously it is not as good as your cardioplegic solution, because the heart is relatively still, but it is still not bloodless. All right. Next, you can use something called a total circulatory arrest. Now a total circulatory arrest is necessary when visibility and clarity of the operative area is crucial. For example, if you are operating in children, in pediatric surgery, if you are operating on the ascending aorta, or if you are operating on the arch of aorta, in these situations you will need total circulatory arrest. Now in total circulatory arrest, the core body temperature is decreased to 15 to 18 degrees Celsius. That means you are inducing profound hypothermia. Some of these Indian examiners, they are very fond of terms. So they will ask you what is the temperature. Profound just means deep, but because it is mentioned in Bailey and Love, it becomes a question. So the question is, what is profound hypothermia? What is the temperature? This profound hypothermia is 15 to 18 degrees Celsius. So you can decrease the body temperature up to 15 to 18 degrees Celsius. Now for every 7 degrees Celsius decrease in temperature of your body temperature, your metabolism decreases by 50%. So whatever is my normal temperature right now, it is around 36 to 37. That is your normal temperature, normal body temperature. So when you decrease it to say 30 degrees, so there is a 7 degree Celsius decrease. So your metabolic rate will decrease by 50%. So assuming your temperature is 37 and your metabolism is 100%. When it is 30 degrees, this becomes 50. When it is 23, this becomes 25. When it is 16, this becomes 12. So when you are reducing the core temperature to 15 to 18 degrees Celsius, this here, your metabolism is only 12% of what the metabolism is at the normal temperature. So now how long can this circulatory arrest be tolerated? It can be tolerated for up to 20 to 30 minutes. Now supposing you are using circulatory arrest to do a surgery, it is only up to 30 minutes. Now supposing it goes slightly longer, supposing you finished your limit of 30 minutes, then you need just a few more minutes to operate. So what can you do? You can use additional cerebral protection via ice packs around the head. I'm sorry, I said ass packs. If you use ice packs around the head, you will get additional cerebral protection. You can also use certain drugs which will decrease the brain metabolism. You can also use cerebral perfusion techniques. For example, the axillary artery. Now, if you will recall, while I was discussing the cannulation sites, I had said, I've written this in light green over here, selective cerebral perfusion. This is an advantage of the axillary artery. So if you were wondering back then what is this advantage, I have mentioned this advantage over here. Where am I? Yes. So you can get additional cerebral protection. Now this image taken from Sabiston, it is a surgeon's view of the heart after cannulation. So you can, I'll use a lighter color. So first we have used an aortic cannula. Secondly, we have used a venous cannula. This is connected to this. This goes to the circuit. Then we have used. I'll use a different color now. We have used an aortic cross clamp to isolate the heart, and then we can use either an. I'll change the color again. We can now use either an antegrade cardioplegic solution or a retrograde cardioplegic solution. Okay. Now you have finished. Let us move ahead. Now you finished operating on the heart. Now you need to discontinue cardiopulmonary bypass. So how do you do it? Now at the end of the procedure, now the procedure is over, you have to meticulously exclude air from the cardiac chambers. This has to be specifically emphasized upon, because you would not want an air embolism to occur. So you've done your surgery wonderfully, but you've forgotten to exclude air. That will cause air embolism. It will cause ischemia of an organ distally, and it will create complications. So you exclude air from the cardiac chamber. Now after you excluded air from the cardiac chamber, blood from the heart can go back into the systemic circulation. So you do not need the heart to be isolated anymore. So you remove the cross clamp, and perfusion is, so once you remove the cross clamp, perfusion is restored to the coronary arteries. So if you remember, we have applied the cross clamp at the aortic root, and the origin of the coronary arteries are blocked. So the heart becomes isolated. Now once you remove the clamp, blood is flowing again from the from the root of the aorta via the coronary arteries into the heart. Now once the coronary perfusion is restored, two things can happen. The heart can either beat spontaneously, or the heart might not start beating spontaneously, in which case there is a heart block, or it is beating but there is post-op bradycardia. In this event, you will use epicardial pacing wires to come back to normal sinus rhythm. All right. Now supposing the heart beats spontaneously, you are going to look at the monitor and look at the ECG to see whether it is in sinus rhythm or not. Supposing if the patient is in V fibrillation, you will use cardioversion to revert back to the normal rhythm of the heart. Supposing there is no V fibrillation, then there is no need to worry. So now we are discussing discontinuation of the cardiopulmonary bypass machine. So we have restored the function of the heart. So now we need to rewarm the patient, because we have decreased the core body temperature. Now we need to correct acidosis, which is happening because there is anoxia. So there is anaerobic metabolism happening. There is a lot of glycolysis happening. A lot of lactic acid is accumulating, which will decrease the pH and cause acidosis and hypokalemia. We need to correct both this acidosis and the hypokalemia. All right. Once this is corrected, then you will restart ventilation. Now what ventilation are you restarting? You are going to restart the ventilator that you had stopped, that is your ventilator which you use in any surgery when the patient is undergoing general anesthesia. You restart that ventilator. All right. And then, so now you've removed, you've not yet removed the cannula, but what you have done is you have discontinued the cardiopulmonary bypass machine. Sorry, I am mumbling. We were discussing discontinuation of the cardiopulmonary bypass machine. You remove the cross clamp and the perfusion is restored. All right. Now the order in which this is restored is reverse of that in which we initiated it. So the last thing that we did was to isolate the heart, but the first thing that we do in discontinuation is you restore the perfusion to the coronary arteries. Once you do that, after that you are so now the heart gradually takes over the circulation. All right. So now while the heart is gradually taking over the circulation, we will want to reduce the arterial flow from the cardiopulmonary bypass machine. All right, because we want the heart to gradually take over. So once the heart is beating adequately, we know this by measuring the blood pressure. So, supposing the blood pressure is adequate, we know that the heart function is now adequate. We will discontinue the cardiopulmonary bypass machine, we will off the machine, we will remove the cannula, and we will suture the openings in the vessel, great vessels from where we entered the cannula. Now, you will give protamine to the patient. If you remember, initially I had told that before you start, before you connect the patient to the, before you cannulate the patient for the cardiopulmonary bypass machine, you are going to have to fully heparinize the patient. So, now you are going to reverse that heparinization by injecting protamine. Okay. So, now we have discussed, we have a brief overview of the cardiopulmonary bypass machine. Now, let us look at the complications. Now, complications can occur at various steps. Now, while you are inserting the cannula, what complications can happen? The patient can suffer an aortic dissection. So, this is an iatrogenic, I will use a different color. This is an iatrogenic aortic dissection. That means you are giving this aortic dissection to the patient, or they can also be atrial injury. Now, when you are starting the CPB circuit, supposing the oxygenator does not work. So, this is oxygenator failure. Secondly, at the end of the cardiopulmonary bypass machine, because there is a lot of inflammation happening, because the blood is exposed to a non-physiologic surface, there might be coagulopathy because the virtuous triad is disturbed. Now, because the blood is being exposed to a non-physiologic surface of the CPB circuit, what happens is there is a lot of inflammation happening. There is activation of inflammatory cascades, various inflammatory pathways, which gives rise to a post cardiopulmonary bypass systemic inflammatory response syndrome, that is post CPB SIRS is occurring. If that SIRS is not being controlled, it can lead to MODS. MODS will obviously then can result to in death. So, now as you have realized by now, a cardiopulmonary bypass machine is a very complex technique. It requires careful interaction as well as communication between the surgeon, the anesthetist and the perfusionist. Perfusionist is the technician who is monitoring the cardiopulmonary bypass circuit. So, because you need to have good coordination and good communication between these three people, the surgeon, the anesthetist as well as the perfusionist, to ensure that the patient remains safe. So, now this video is over so far as the CPB machine is concerned, but so you can stop the video now. There is no new information which is going to be presented now, but let us recap. In case you want a brief overview again, let us recap. So, this diagram is taken from Sabiston. This is a total cardiopulmonary bypass circuit. So, see, all returning blood is siphoned into a venous reservoir. This venous reservoir, if you remember, is placed 50 to 70 centimeters below the level of the heart. So, via gravity, it drains into the venous reservoir. Via the venous reservoir, the blood comes, it goes into the circuit. Now, it has entered the circuit. So, there is a heat exchanger and an oxygenator over here. After the oxygenator, it is red because the blood is oxygen again. It is going to come back to the body. So, it will come via a centrifugal pump, and via centrifugal pump it enters into the ascending aorta via the cannula, and it enters the systemic circulation. Now, some amount of blood, if you can see this lower loop over here, it will go into the cardioplegia pump. This cardioplegia pump is where the cardioplegic solution is being mixed. This cardioplegic solution is mixed in a 4:1 ratio. All right, and this, as you can, so now the blood has come, it is being mixed with the cardioplegic. It comes, the blood is coming, and it can enter the, we can use this cardioplegic in two routes, antegrade and retrograde. All right. Now, see, during the retrograde administration of cardioplegic solution, the flux of blood from the coronary ostium is siphoned off through a sump drain. Okay, this is the sump drain. This sump drain is not shown in this particular image in Sabiston, but because of some efflux of blood from the coronary ostium, some blood is coming out. That blood is being siphoned off through a sump drain. All right. Okay. Now, supposing in the exam you want to draw a diagram of this cardiopulmonary bypass circuit, and you feel that the images that I have shown you so far, the one from Bailey and Love and this one from Sabiston, is complicated. Here is one diagram which I used for my exams. So, this is the heart. The red is the oxygen blood, the blue is the deoxygen blood. Now, you can see over here, I will use, what color do I use? I will use this color. You can see over here the blood is entering via gravity into the reservoir. From the reservoir, it is going into the oxygenator and the heat exchanger. Alright. From here, it is going back into the heart. Before that, you need a filter. You need this is an arterial filter. You need this arterial filter to remove any particulate emboli which may have happened. Also, this is your other circuit of a cardioplegic solution. So, cardioplegic solution is entering into the heart. This is your aortic cross clamp. So, as you may have seen over here in this for this diagram, this blood which is entering from the cardioplegic pump, it is entering proximal to the cross clamp. Why is it over here, and why is it proximal and not distal? Because, damn these colors. So, why is it proximal and not distal? Because you want to isolate the heart from the rest of the circulation. Supposing if this cardioplegic solution were to enter the systemic circulation, it would cause other complications. Okay. So, we have discussed whatever is in this color, we have discussed. So, now a few more circuits are left, we will look at that. Before that, you may be wondering, what is this that I have drawn over here, this line with these 3 dots. So, when you go into your CTVS, your cardiac OT, during your CTVS posting, or if you become a cardiac surgeon, you will notice that there is something which looks like this. So, as the blood enters, this will come down and this will go up. When you look at this in the OT, you will realize it. Just for that sake, I have drawn this because this is from an exam point of view. Now, there is something called a gas blender over here. This gas blender, it ensures that oxygen reaches into the oxygenator and it maintains the partial pressure. So, for that partial pressure, we need a gas blender. Now, these two are remaining. What I use a different color now. So, now what are these two things? This is the cardiotomy sucker. Cardiotomy sucker, as you may recall, so the suction that you are using in any surgery, for example, if you are operating on the in the abdomen and you are assisting, the surgeon will give you a suction and tell, okay, you suck all the blood, suck all the fluid away from the operating area. So, this cardiotomy sucker is 1 and this is blue because the blood is deoxygenated. Now, this is the vent. This is red, which means it is oxygenated. Now, you might be wondering where is this blood coming from. So, let us come back to this diagram from Sabiston. This sump over here, right? Let me erase everything else. So, this sump over here, which I had left empty the previous time, as in which this Sabiston had left empty. He is not connected to the main circuit. This sump is being what is referred to the vent over here. Alright, so this concludes this discussion on the cardiopulmonary bypass circuit. Since surgeons usually we are not exposed to these postings, we do not see this being used on a daily basis. It is slightly difficult to understand. So, I hope I have made your concept slightly clearer. So, when you go back to your book and when you read the cardiopulmonary bypass machine, I hope you understand this topic. If you have any doubts, if you have any questions, please leave it in the comment section. Thank you.